With that, I'd like to welcome Alexander Fay from Retrotope to tell us about the therapeutic trial of RT001. Thank you, Alexander.
Right. Good morning, good afternoon, everyone. Just one correction there. I'm at a university hospital. I'm part of the Retrotope trial, but I don't work for Retrotope. Can everyone see my screen okay?
We do see your screen. Just 1 second. All right, now you can go, Dr. Fay.
Can you hear me okay?
Yes, we hear you good. Thank you.
Hello, everyone, and thank you to the organizers for the invitation to speak with you about our work with INAD. So I'm a pediatric neurologist at the University of California, San Francisco. I focus on peripheral nervous system disorders, and I'll be speaking on behalf of myself and our collaborators, Darius Adams, who's site director for the trial in New Jersey, and then our study sponsor is Retrotope, which is a company that's in the San Francisco area here. So I'm not an employee of Retrotope. I'm a University of California employee, and I have no other disclosures. So here's what I'd like to talk to you about today. We've already had really excellent reviews of details of INAD natural history and some of the exciting things happening therapeutically. So I'm not going to focus too much on the INAD clinical features. I do want to talk to you about the rationale for RT001 and how that fits into pathophysiology of INAD, and then our development of a rating score that we've used in this clinical trial, a little bit about the clinical trial design, and then the progress of the trial to date and the impact of COVID-19 on carrying out the trial. What I won't be discussing today, because we don't have all the results in yet, are the findings from the trial, but hopefully the next time we meet, we will be able to talk about that. So as it has been reviewed already this morning by the three previous speakers, INAD is an ultra-rare disease. It's recessive, associated with mutations in the phospholipase A2G6. The onset is typically between 3 months and 3 years of age, and it's relentlessly progressive from there, leading to effects on muscle tone, loss of developmental milestones, peripheral neuropathy, optic atrophy, hearing loss, and cerebellar atrophy on the MRI being one of the early findings, and the iron deposition typically being a later finding and not really helpful in making the early diagnosis. And then with the relentless progression, death typically ensues by an age of 6 to 10 years, largely from bulbar insufficiency, respiratory, and swallowing problems. And there are no currently available treatments, and there haven't been any standardized metrics that we could use to follow progression of the disease. There's been a recent natural history study of 48 patients published earlier this year that some of my collaborators were a part of, and it gives a sense for the progression of disease and when various milestones tend to be lost, starting with balance difficulties before 1.5 years, progressing to involve other motor and language areas, and the bulbar dysfunction setting in a little before 5 years of age, progressing to language regression and ultimately death by 10 years of age. We know that mutation types matter. So if we look at truncating mutations in orange versus non-truncating mutations in blue, there's an earlier age of onset of symptoms across developmental domains for the truncating mutations compared to the non-truncating forms. So with that little bit of background about INAD natural history, I want to talk to you about our approach to using this molecule RT001. So you've heard some really nice introductions to how to address the phospholipase A2 deficiency in this disease, which I think is going to be a critical part of treating it. And what phospholipase A2 does, or one of the things it does, is help to recycle damaged lipids in lipid bilayers in the mitochondria and other metabolically active areas of the cells. And all of us have reactive oxygen species damage to our lipid membranes in the course of normal metabolism. But if we have intact phospholipases and other enzymes that can recycle those damaged lipids and replace them with normal ones, then it's not so much, we don't develop neurological disease. However, in the case of absence of phospholipase A2, these damaged lipids can accumulate and eventually form some of the pathologic features like spheroid bodies. And ultimately what we see in INAD is degeneration of both central and peripheral neurons. And so while the goal of gene therapy or some of the approaches Dr. Kotzbauer talked about are to improve phospholipase A function, the goal of RT001 is to reduce oxidative damage to the lipid membranes. And this oxidative damage is a free radical chain reaction that just amplifies through the membranes, damaging neighboring lipid groups. As I said, these damaged lipid groups can't be recycled well in INAD. So RT001 is a very slightly modified variant of polyunsaturated fatty acid, linoleic acid, that we all consume in our regular diets. It's high in flaxseed oil, as an example. And the only difference with RT001 is that these two hydrogen atoms are replaced with deuterium atoms. And the effect of that is the isotope effect, which strengthens that carbon-hydrogen bond when it's replaced with deuterium. And that can inhibit the labile free radical loss of hydrogen that happens at that site in the case of reactive oxygen species exposure. And so getting the RT001 to about 20% occupancy in lipid membranes is enough to stop the peroxidation chain reaction. And this was shown in some early studies of adults with Friedreich's ataxia, where oral dosing of RT001 was able to achieve membrane occupancy rates of up to 45%. And before our study, there were 2 children that were treated with RT001 and tolerated it well, taking 2 to 3 daily oral doses. Prior to initiation of the trial, some preclinical data were also collected about RT001 in patient fibroblasts. So in the red and the gray, you can see fibroblasts from 2 patients with PLA2G6 mutations. Looking at lipid peroxidation rates, you can see that there's no abnormal elevation of lipid peroxidation in the controls, and RT001 has no effect on the controls. But in the case of the 2 patients, RT001 significantly reduces the amount of lipid peroxidation. And similar findings were found in a fruit fly model of INAD. RT001 was not tested in the mouse models that we heard about earlier today. So we had our clinical approach to INAD with an inhibitor of lipid peroxidation. But before we started the trial, we really felt that we had to develop a rating scale that would be appropriate for tracking progression of these children with INAD. And at that time, there was no validated scale to monitor progression. And many of the other diseases that I treat have rating scales that have been validated, particularly spinal muscular atrophy and Charcot-Marie tooth and motor neuron disease, cerebral palsy. But INAD is really unique in its combination of central and peripheral nervous system features. And so we didn't think that we could just pull one of these scales from another disease and use it directly, but we had to develop our own scale that would cover the relevant domains that are affected developmentally in INAD, including gross and fine motor bulbar, ocular, temporofrontal, and autonomic. And so here are some examples of gross motor measures that we looked at. So every item in the INAD rating scale is graded on a score of 0, 1, or 2. So you can see, for example, when grading whether a child can hold her head upright against gravity while sitting. If she can't do it for at least 3 seconds without support, that would be a 0. And 3 to 15 seconds would be a 1, and more than 15 seconds would be a 2. And you can see rolling over and sitting with support are scored similarly. And then here are some other examples from the ocular part of the scale. So tracking a human face, a child who can't track would get a 0. Tracking or fixing gaze for 2 seconds would receive a 1, and then following a person throughout the room would receive a score of 2. And so incorporating data from the early part of the trial, our 2 baseline visits, as well as some patients in a prospective natural history study, we were able to show that there's a good correlation between the INAD rating scale and months since symptom onset. And in addition to this, we collected data both at baseline and a repeat exam within 2 to 4 weeks. And we found there was a very high correlation. Those scores were essentially identical. So good reproducibility. And then each of our scores were also graded by an independent clinician. And we found there was excellent inter-rater reliability as well. So in addition to the INAD rating scale, which is the primary outcome for this trial, we wanted to look at some secondary outcomes, particularly bulbar function, the bulbar portion of our INAD rating scale, because this is so correlated with morbidity and mortality in these children. The modified Ashworth spasticity scale, which we use for looking at muscle stiffness and cerebral palsy in particular. The Hammersmith and Chopin-10 scores, which are used for spinal muscular atrophy and have been very helpful for following hypotonia in clinical trials for SMA. We wanted to incorporate parental impression scores, electroencephalography or EEG, the nerve conduction tests in the lower extremities, brainstem evoked response audiometry, and the ophthalmologic exam. So our inclusion and exclusion criteria, basically we just wanted to make sure we had children with classic INAD and not some of the other variant forms. So they had to have a history consistent with classic INAD, onset of symptoms between 6 months and 3 years, genetic findings consistent with PLA2G6 deficiency, impairment in at least 2 of the categories that we assessed. And then we excluded any children who had atypical forms of neuroaxonal dystrophy and any of those who seemed like they were in the end stages of the disease, life expectancy less than a year, or requiring substantial mechanical ventilatory support. And we ended up recruiting 19 subjects to our 2 sites in New Jersey and San Francisco. Patients came to us from 4 continents, and the ages at enrollment were age 2 years to 7 years. And we enrolled all of these patients over about a 9-month period. The families covered most of the travel costs, but we were able to help out with housing at our site with our hospital family house. We also had a dietitian who would counsel the families about a low-fat diet, because RT001 is a linoleic acid variant and we want it to achieve high percentages of occupancy in lipid membranes throughout the body. We want less additional polyunsaturated fatty acid being taken in the diet. And so our dietitian worked with the families on this. And then safety monitoring included routine blood testing and pharmacokinetics. And this is just a schematic of the trial with our 2 initial screening visits, a baseline, and then a day 1 study visit 2 to 4 weeks later. And then we have done visits every 6 months and then offered to the families a 12-month trial extension with visits at day 540 and 720. So the progress of the trial to date, before COVID affected all of us, we'd completed 2 of our 12-month visits. Unfortunately, one patient died over last winter from influenza infection. We've had a couple other subjects who had to be hospitalized for respiratory infections through the winter months, which is not unusual for kids with low muscle tone and disorders like INAD. But we haven't had any major adverse effects overall related to the study drug. And we offered all of the subjects to do the 12-month extension, and all of the families accepted this offer. We've since had one family withdraw because a child was moving towards hospice and the parents wanted to limit blood draws and hospital visits. But COVID-19 really threw us for a loop because we were just getting ready to have all of our 12-month visits throughout the spring and summer of 2020. And since many of our patients were coming from other countries, obviously people didn't want to travel to the US given the COVID situation here. And so we had to figure out ways to complete the 12-month visits remotely. So what I ended up doing was training local child neurologists or pediatricians to perform the INAD scales and other clinical measures. And then I observed their exams of each of the children, and I scored them myself through Zoom for the 12-month visits. And then we're continuing with this for the 18-month and 2-year visits. Fortunately, all patients have been able to continue RT001 uninterrupted through the year of the study and on into the extension phase. So our future directions at this point are to complete the 12-month extension through next summer, to complete the analysis of our 12-month trial data. So we'll be able to share with you more details on the outcomes. And we have a natural history study that's in progress at several international sites that's going to serve as our control group. I think doing a randomized placebo-controlled trial in an ultra-rare disease is extremely challenging. And so natural history cohorts have been serving as control groups in many of the gene therapy and other trials that are happening in rare and ultra-rare neurological diseases. And so really, I want to thank first and foremost all the patients and families. They've really been the heroes throughout this process and adjusting to all the changes with COVID-19. So I'm very grateful to them. Our research coordinators at UCSF have been extremely helpful, particularly Kate Sievers. I'd like to especially thank Sarah Endeman at Retrotope, who's been a wonderful advocate for the families and interfacing with them. Dr. Darius Adams, who's my counterpart on the East Coast in New Jersey with the clinical trial, and then our collaborators at Retrotope, Frederick Hearings, Paul Deep, Peter Milner, Mark Madej, and Jerry Wool, and Elliot Schur, one of my colleagues at UCSF, who got me involved in the trial, and then UCSF Family House for helping with lodging for our patients when they traveled. And I will end there and happy to take any questions.
Great. Thank you, Alexander, for a very informative talk. I'm going to start the questions. I have 3 questions. First of all, thank you for just sharing some of the preclinical pathophysiological kind of rationale behind your approach. I think this ties in with Odie Sabone's question. She's asked, can you explain why RT001 is protective for an INAD? Why is the D4 molecule more stable? And to add on to that, can you provide us with the evidence that RT001 crosses the blood-brain barrier?
So it is lipid-based and does cross the blood-brain barrier. I don't have a slide that shows that, but it certainly does get into peripheral nerves and central nervous system.
And which model have you used to show that in?
The Drosophila model was the one that was used, and in the preclinical data. But
And have you, in a mouse model or something?
We don't, we don't have data from the mouse models. I think that would be certainly an appropriate thing to do, but leading up to the clinical trial, we didn't have that data.
So you had data showing that RT001 was present in Drosophila brain from knockout animals or wild type animals?
Yes. Well, that wasn't our group. That was other researchers who did that prior to the clinical trial.
And can you answer Odie's question about why is that, why is it thought to be protective in INAD? Yeah,
so I think simplistically speaking, there are kind of two approaches. The ones that we heard about earlier today with gene therapy would be actually replacing the enzyme that is defective, the PLA2G6, and the other would be to kind of prevent some of the toxic substrate accumulation that happens in INAD. And so one of the mechanisms for toxic substrate accumulation is reactive oxygen species damage to lipid membranes, particularly in the mitochondria. And I think that's been well characterized in some of the mouse models with showing mitochondrial injury. And so the idea behind RT001 is to prevent the lipid oxidative damage in especially mitochondrial membranes, but also other membranes as well, and that might compensate somewhat for the lack of ability for patients with INAD to recycle these damaged lipids.
Okay, so as a consequence of INAD dysfunction is what you're targeting. Penny Hogarth has asked, what was the lower age limit set? Why was the lower age limit set at 18 months? Because obviously some diagnoses are made before that.
Right. I think it's pretty rare for the diagnosis to be made much before that these days. All of our patients had a kind of a diagnostic odyssey, often many months to a year, the only exceptions being children who had a sibling who was affected previously and so were maybe diagnosed pre-symptomatically. We wanted the children to be able to complete all of the clinical measures and felt that we wanted a little bit more of a somewhat homogeneous age group rather than going down to the early infantile part of the spectrum. But I certainly think it's critical to think about what would happen if we treated children at even earlier stages. And this goes for gene therapy and RT001. If we can treat children in the pre-symptomatic stages, we may get more efficacy. That's certainly been borne out in the spinal muscular atrophy trials. So I think it's a great point, and I think going forward we should try to incorporate the earliest onset ages in these trials.
And then can I ask a question? Have you seen any deterioration in liver function, including LDH, in any of your patients set? You said no adverse side effects, but have you seen any worsening of liver function tests, including LDH?
There have not been dramatic increases. So we've followed the transaminases and LDH, and essentially all of the children have an elevated AST, more than ALT, but both of them tend to become elevated. There is some elevation over time that we've found over the year, but certainly nothing looking like a fulminant liver failure pattern. LDH is about twofold, threefold higher in many of these children, but that has seemed to be pretty stable so far.
And you haven't seen it worsen with RT001?
No, it hasn't seemed to worsen significantly, no.
And last question. So there's a question, would RT001 be useful in combination with gene therapy?
Yeah, I think that's an excellent point. I care for a number of children who are on gene therapy for spinal muscular atrophy, and as amazing as these treatments are, it's fair to say that they're not cures. And so even with a gene therapy, which I think is really the most promising thing out there for these rare recessive diseases, I still think we need to be exploring other disease mechanisms and other ways to modify the progression. And in particular, I would encourage researchers to look into combining treatments for neurodegenerative diseases.
I think we'll have to stop there. There's a few more questions, Alexander. If you wouldn't mind answering them on the chat, that'd be fantastic, particularly relating to trial design and controlled diets from Penny Hogarth. It'd be great if you could answer those. So thank you very much for a very informative talk.